right, welcome to Wonderful Wednesday, part 2, STEMI, only you can decide. So I'm really grateful that you've joined today. We're going to move kind of quickly through a little bit of review, and then we're going to move forward to the second half of STEMI, only you can decide. So I always want to remind you when you're evaluating your EKG, there are 4 basic questions you have to ask. First question is you ask about normal electrical direction. And when we're looking at chest leads, we are looking in V1, which is a right-sided lead, we're looking for a downward direction. And in V6, we're looking for an upward direction. Same event, 2 opposite sides of evaluation. Normal voltage, actually in any lead. So the downward in V1 should never be greater than 10 small boxes or 1 millivolt. And the upright in V6 should never be taller than 10 small boxes or 1 millivolt. So normal electrical direction, normal voltage, and then we look at the time. The time is from the beginning to the end of the QRS, making sure that that time is less wide than 0.12, which is 3 boxes. And then we talk about normal R-wave progression. Now, R-wave progression is something I've talked about a lot. I'm not going to talk about it too much now because I really do want to move to the second half of this course. But if you need to know more, please get on my YouTube channel and look at step 1 of STEMI or part 1 of STEMI, and then review part 2. Okay, so really important to remember whenever we see this patient, diagnosis is always going to be based on 4 basic criteria. First of all, if the patient has a history or if he can share the history. Secondly, does it look like, sound like, seem like a STEMI? And most particularly, do you see ST segment elevation? That ST segment elevation must be in 2 or more of a contiguous lead group. So what that means is it must be in 1NL, or it must be in V5 and 6, or it must be in leads 2, 3, or AVF. It's got to be in at least 2 leads. It can't be in only 1 lead. It's not meaningful if you only see it in 1 lead. And you have to see it in 2 leads that look at a surface area of the heart. And step number 4, is it big enough to create electrical changes that are seen in a mirror image on the opposite side of the heart? And that is known as reciprocal change. So when I look at an EKG, I'm giving a quick eyeball and I'm saying, okay, voltage looks okay, width looks okay, direction is right, and I'm looking for ST segment elevation. I don't really find elevation, I see depression. ST segment depression can mean that your patient is having a non-STEMI, but always you have to look at the opposite wall to make sure that you don't have ST depression on one side and ST elevation on the opposite side. ST elevation means full wall thickness. We used to call it transmural. It means that you have damage across 3 layers of the heart, and that's enough damage that you're going to see it on both sides of the heart. So this is how we're going to think about our leads. So looking at a 12-lead EKG, as I look at a 12-lead EKG, it's going to always be vitally and profoundly important for me to separate leads into the leads that look at the surface area of the heart that I think is being injured, and the leads that are on the opposite side of the heart. So septal leads, V1 and V2, V1, V2 facing the anterior septum, the back of the chest, normally a place you're not doing EKG, is V7, V8, V9. Those will be your reciprocal leads. Those are posterior place leads. Typically, you're not going to place those. You don't generally place them in a normal EKG, but you want to know that's what's going to show you reciprocal. For pure anterior, that will be V3 and V4, pure anterior. V1 and 2 are anteroseptal. V3 and V4 are pure anterior, and the reciprocals are V7, 8, and 9. Lateral leads. 1L, that's high lateral. V5, V6, that's low lateral. They have easily accessible and evaluable reciprocal leads because that reciprocal leads are inferior. So if you just take a look at my heart is laying like this. Here is the lateral, here is the inferior. What happens in the inferior wall is seen on the lateral, and what happens in the lateral wall is seen in the inferior. Those are the absolute reciprocals. In fact, so much so that when the AHA produced STEMI, They had a fantastic program called STEMI, and they said, you've got to have reciprocals. But the problem is the only time we actually see pure reciprocals is with inferior and lateral, because everything else requires posterior evaluation. We're not doing that normally. So really important to remember, the only place you see true reciprocals are inferior and lateral, which are in direct opposition from each other. Everything else that you're doing across the front of the chest, you can only see reciprocals on the back of the chest and the posterior surface. So that's really important, because a lot of discussion occurs around reciprocal changes, but don't expect reciprocals if you've got septal or anterior changes on your EKG. You're not going to see any reciprocals unless you do a posterior exploration. So that really does explain what is reciprocity, and reminds us that the only two main areas of the heart where you see reciprocity are inferior and lateral. Now, if I have a septal change, I'm going to see it in the posterior wall. If I have anterior change, I'm going to see the reciprocal in the posterior wall. But what that also means, so if I'm talking about front, anterior, and back, posterior, what that also means is that when I'm infarcting my posterior wall, where I would expect to see ST segment elevation, I'm going to see anterior reciprocals. That will be ST segment depression. It is never normal, ever, to see ST segment depression in V1, 2, or 3. Never. You often will see ST segment elevation. You should never see ST segment depression. Never. So when you see an ST segment depression in V1, V2, or V3, your question is my patient having a posterior infarct? And typically, posterior infarcts, not always, are seen with inferior changes as well, but you can also have isolated posterior infarcts. So that's really, really, really important. So remember, the direct problem is where you have ST segment elevation. The opposite is the reciprocal. The only true opposites are inferior and lateral, and inferior and lateral are directly opposite each other. So if I'm having inferior ST segment elevation, I should have lateral ST depression, and vice versa. And if it's anterior, anteroseptal, or anterior, I would see reciprocals in the posterior wall. I'm not looking there. If the posterior wall is having a STEMI, I'm going to see ST depression in the primarily in V1, V2, V3, but you can also see it in V4. So you never see ST depression ever in chest leads. Anytime you see ST depression in chest leads, you should be concerned that that is reciprocal for a posterior infarct. And posterior infarcts are missed, and they are deadly. I mean, deadly. Now we know that one problem is that most of what's reported as STEMI is not myocardial infarction. And by the way, most providers can't tell the difference. It's really hard. Really, you need a cardiologist to help you with that. It's really important to appreciate that the #1 cause of ST segment elevation in emergency department chest pain patients, #1 cause, left ventricular hypertrophy. Okay, so remember at the beginning, I said, when you look at your EKG, you're looking at voltage. You should not have more than 1 millivolt on your left-sided leads, V3, V4, 5, and 6. And you should not have a greater depth on your right-sided leads, greater than 10 millimeters. So just being aware that when you see abnormal voltage, really tall or really deep, not asking you from this little class to be able to diagnose hypertrophy. I'm saying when you see a lot of voltage, you should expect with left ventricular hypertrophy. So big R on the left side leads, 4, 5, and 6. Deep S on the right side leads, V1, V2, V3. Before you call for a STEMI alert, make sure you've evaluated the fact that with left ventricular hypertrophy, you will have ST segment elevation, V1, V2, and V3. The most common cause for false activation of the cath lab is left ventricular hypertrophy. The second most common cause for false activation of the cath lab is left bundle branch block. Now, left bundle branch block just means that your depolarization time, the width of your R wave, is greater than 0.12 seconds. The current is going towards the left, as it always does, but it's taking a lot of time. So those are the two major reasons that we see abnormal ST segment elevation in V1, V2, V3. And that tells us to be very cautious, very, very cautious. In this study, this was 902 patients in the emergency department. STEMI mimic, which were these things, and most particularly LVH and LBB, 6 times more likely than an actual STEMI. 6 times more likely than an actual STEMI. Wow. Okay, that's really, really, really significant. MI is really a low percent of this. Only 15% of patients with ST segment elevation have an MI. 85% have a non-MI diagnosis. So that means if you're in the ICU, you're not in the ECC, you have a patient post-cath, you have a patient post-CABG, you have a medical patient who might have some risk factors for STEMI, and you're looking at ST segment elevation V1, V2, V3, rule out first the 2 easiest things for you to rule out: left ventricular hypertrophy and left bundle branch block. Okay. Now remember, this is part 2 of something we did last week. So it might be feeling rather fast for some of you, but it really is based on what we did last week. And we spent an hour on basic evaluation last week. Okay. Now, the other thing is R wave progression. Just as a reminder about R wave progression, when I look at my chest sleeves, I expect in V1 to have a very small upright. And by the time you get to V5, I expect to see a relatively big upright. So as you're looking at this picture, you can see that staircase from V1 to V6. That is known as R wave progression. The other thing that's really important with R wave progression is what we're looking at right here in V4, which is when the upright becomes bigger than the downward. That is known as a zone of transition. And zone of transition is actually R wave progression, and zone of transition are affected when you have hypertrophy, when you have bundle branch block, and when you have an anterior myocardial infarction. It's not affected by inferior, it's not affected by lateral, it's affected by anterior myocardial infarction. So we always remind ourselves cause of R wave, poor R wave progression, LVH, RVH conduction deficits. You see it with pulmonary disease, and you see it with anterior or anteroseptal infarction. So those are the things I want everybody to remember. Now we take a look at this EKG, and you can see here's your first little R, then your next R, it gets a little bit bigger, it gets bigger after that, and bigger after that, and not quite so big here. This is called good R wave progression. And then we look at this one. You might say, well, that R wave progression looks good. Look how big the R wave is in V1. That's absolutely abnormal. More upright than downwards in V1. This is an early zone of transition. So remember what the 3 things are that cause an alteration in your R wave progression or your zone of transition: bundle branch block, hypertrophy, or infarct. So the very first thing I'm going to do is look at how wide this is. This is actually a right bundle branch block. Early zone of transition, and the width is wide. The next thing we're going to look at is the troponin. And that's a really pertinent lab. It's really, really important. Here at Grady, we do high sensitivity troponin, and it's really, really important to appreciate high sensitivity troponin. Same troponin you always measured, it's just diluted differently. It's exactly the same troponin you have always measured. So here's the facts. What you used to look at when you looked at regular troponin is that you looked at it as nanograms in milliliters. So the resulting level was 0.04. At 0.04, your patient may actually have significant myocardial injury, but you can't see it because of the troponin level that you're using. So we use high sensitivity troponin. It's just a different dilutional quality, and that is 1,000 times your old troponin. So if my patient had a troponin level of
a nurse from the floor called, and she was asking about whether or not she needs to
make sure you're muted. I muted you. Okay. People forget. No problem. Okay, so high sensitivity troponin. My patient has a troponin level of 0.05, and multiply that times 1,000. That becomes 50. Their troponin level is 50. That's an extraordinary high troponin in high sensitivity language. That's why we do high sensitivity troponin. That's the reason we're using high sensitivity troponin. You want to know more about it? Watch that YouTube video. I don't think that's me, but it might be. I can't remember because I have a bunch of videos on it. Okay, so just taking a look at our patient, what we're going to see here is you see right down here is their high sensitivity troponin, and high sensitivity troponin is 36. Now, in your old language, that would have been less than 0.04, which meant your patient had a high troponin level that you were missing because you weren't looking at numbers less than 0.04. Multiply 0.04 times 1,000, that's 40. Okay, that's significant. Anything in men greater than 20 is significant. Anything in women greater than 15 is significant. This high sensitivity troponin is 36. This is significant. And that's the reason we have transferred over to high sensitivity troponin. Okay. Now, in addition to that, when we're looking at this patient, he also has a very significant lactic acidosis and high liver enzymes. He's got a lot of other abnormals that are going along with that. Things that actually can help us to evaluate our patient's cardiac dysfunction, high sensitivity troponin, LDH, which we don't have, and then this beta hydroxybutyric acid. I just think I put that up there to remind you that when your patients are hyperglycemic and ketotic, that is very dangerous to the myocardium. And on this patient, this was a patient that I was reviewing his chart. He actually remained in ketosis and hyperglycemia for about 10 hours. That probably extended his infarct quite significantly. We're going to look at his EKG in just a minute. So, okay. Now we take a look at his liver enzymes, and you can see also those liver enzymes are very elevated. So he has cardiohepatic, he also has cardiac renal dysfunction. He's a sick guy. It's really hard to evaluate him. Sometimes we poo-poo troponins and EKGs on somebody who looks quite this sick. Okay. This patient gets admitted to this CVICU here at Grady Hospital. And here's his very first blood gas, right? Here's his first blood gas. And you can see he looks pretty okay here. And then he gets really bad. So you can see he went from having a base deficit of 2.5, that was this excess, and down to negative 1.5, and then down to negative 0.67, negative 0.78. And his lactic acid was elevated, and he was ketotic. So he was the patient that really needed for us to have a bigger, wider perspective about what was occurring to him. Now, we're going to take a quick look at some EKGs that correlate back to this patient and others. We're going to remind ourselves that LVH is the single most common STEMI mimic, and that it may or may not present with ST segment changes. And there are some particular criteria. It's called the Scarbosa criteria that can give us a lot of information about that patient. Might be very hard for us to actually evaluate with LVH whether or not a patient is really having an EKG, in a STEMI. All right, so let's take a look at this. So here we are with the patient, and what we're looking at when we first evaluate this patient, we're not going to, you guys in my class are going to evaluate that, but everybody here, all you're going to look at is R wave progression. So you can see you have a little R here, a little bigger here, the same size here, the same size there. You don't get bigger until you get to V4 or V5. So we're going to say V5 is our zone of transition. And we're going to look at that voltage. So now look at that voltage. Here are your left-sided leads, 4, 5, and 6. Choose the biggest one. And in a 1 millivolt signal, each box is worth a millimeter. So I'm going to say 5, 10, 15, 20, 25, 30. He's 30 high here. Remember, you're not supposed to ever be more than 10. He's 30. And then I go over to the deep wave on the right side of the lead, V1, V2, V3. And I've got this deep downwards. This is also right around 20. So I'm 20 down, 30 up. I'm going to add those two together. That's 50 millimeters. This patient has the right current direction, which is to the left, a really big voltage and late transition. This is LVH. Okay, so we take a look at this patient. And this one is a little harder for me to see. So we look at V1, V2, V3. So this is kind of a divided EKG, V1, V2, V3, and V4, V5, V6. And you can see here in V4, you got a really, really big upright. And here in V1 and 2, you have a really big downwards. This is also LVH. Now, what's important when we looked at that LVH is we see this minor ST segment elevation in V1, V2, and V3. Really, really important. Here, I also am seeing some minor ST segment changes, but look at this. I have ST segment depression. What did I tell you about that? Is that ever normal? Ever? No, this patient is actually having a posterior infarct. He also has LVH. Okay. The next thing to look at bundle branch block. So bundle branch block occurs when electrical activity in the transmission down the left bundle is delayed. We're still going to depolarize the heart, but now we're depolarizing the heart cell by cell by cell. In left bundle branch block, the direction is normal, but the time is delayed, and you have a poor R-wave progression. So now take a look at this patient. He has a little R here, a little R here, a little R here, hardly any R there. Finally, his R wave gets bigger than his downwards. This is a late zone of transition. And when I look at this, I can say this is really wide. Okay, so direction is to the left. Current is going to the left, but there's a lot of time delay. This is considered a left bundle branch block. Now, what I want to tell you about this is really, really important. Criteria for bundle branch block is an alteration in zone of transition. You should always transition, meaning more upright than downwards in V3 or V4. Early zone of transition, wide R, right bundle branch block. That's all you need to know. All that right rabbit ear stuff, which less than 10% of patients present with, don't worry about that. Right bundle branch block, early zone of transition, wide R wave. Left bundle branch block, late zone of transition, wide R wave. That's really what you need to know. And this is left bundle branch block. Now, I'm going to ask a student in my classroom who's actually in my classroom, do you have something else? Just in terms of what we've talked about. Look how down you are on the right side and how up you are on the left side. Now, that up on the left side is smaller than you would expect with left ventricular hypertrophy because of the left bundle branch block. This is a patient with both left bundle branch block and left ventricular hypertrophy. Now, if you were looking at this EKG, you might say, oh my God, look at that ST segment elevation. I'm calling the cath lab now. But you are not having a STEMI. This ST segment elevation, V1, V2, V3, and even a little bit into V4, is all because of left bundle branch block and left ventricular hypertrophy. Again, coming to a class for 1 hour, even to a class for 6 weeks, I don't think that we can say we can make that decision, but what we're not going to do is activate the cath lab. What we're going to do is ask a friend, and that friend will be a cardiologist. So we're going to phone our friends, the cardiologists, not necessarily our APP or our medical resident, because they're going to look at that and say, your patient's having a STEMI. You need a cardiologist to look at this. This is what we call diagnostic uncertainty. You have ST segment elevation, but you have 2 causal factors that might be causing it: left bundle branch block and left ventricular hypertrophy. Fantastic. Oh, you're so kind. Okay, now take a look at this. This is a really important EKG. This is the patient. You are so kind. Thank you. This is the patient who has a ventricular pacemaker. So this is a transvenous pacemaker, which means that the electrode is embedded into the right ventricle and all current will go over to the left heart, and there is completely abnormal depolarization and completely abnormal repolarization. All 3 things are really wrong here, right? You don't have good R-wave progression. You don't have a zone of transition, and you have a wide QRS. All 3 things that I mentioned to you, right? R-wave progression, zone of transition, and QRS width. All wrong here. But this is because you have a pacemaker, not because you have any other pathology. This is a pacemaker rhythm, and you can see your pacing spikes right there, right? So you're going to expect with a ventricular paced rhythm that your direction is going to look abnormal, your zone of transition is abnormal, you're going to have a wide QRS, all because basically, you have a no bundle branch block. Like neither bundle is functional, but you are activating from a pacemaker. And so what's actually happening is the current begins at the apex of the heart and goes to the base. So it's going away from all of my chest leads, and that's why everything is in a downwards direction. Okay, so that makes it kind of hard. So signs that point to an MI, you have to have a basic model for interpretation of your patients and really looking at what's occurring. And that basic model is really ST segment elevation in contiguous leads and reciprocal changes in the setting of a clinical correlation. There's some reason that you think the patient is having a STEMI. And significant means in relative QRS amplitude that your ST segments are elevated. Now, if I have a really small R wave, just a half a degree, half a box of ST elevation could be considered significant. So that's really, really important. Also remember about contiguous and reciprocal, and also remember that changes may be very, very subtle. So again, remind yourself, whenever you're looking at an EKG, choosing your chest leads first. Normal electrical direction should be down in 1 and up in 6, meaning the current of depolarization, primarily downwards in V1, primarily upwards in V6. Normal voltage, less than 10 millimeters up and 10 millimeters down, less wide than 0.12, and most important, normal R wave progression. And again, remember, does it look like a STEMI? Does it act like a STEMI? Are they diaphoretic? Are they vomiting? Is there ST segment elevation? And can I say that's in at least 2 leads of the lead group? Inferior lead group 2, 3, and AVF. Lateral lead group 1 and L and V5 and 6. Anteroseptal V1 and V2. Pure anterior V3 and V4. Pretty simple. Just memorize it. Always remember, if you are concerned, but you're not sure, always ask for cardiology input. Okay, let's start off with CH here. This is a 26-year-old with a sudden onset of 7 out of 10 chest pain and left arm pain. Started at 6 in the morning, presented at Good Sam Clinic, who called EMS and asked to transport the patient to Grady Hospital to the emergency department. Per the paramedic, the EKG shows sinus bradycardia with early repolarization, which means he's got ST segment elevation. He's had chest pain times 1 year since he was diagnosed with pneumonia. So he's had chest pain for a year, which makes you think, well, this might not be cardiac, right? And since yesterday, he's had chest discomfort that's radiated to the neck and the back and on and off since then. He's got a cough. It makes his chest pain worse. And he also has a fever. He has abdominal pain with nausea, and he has been treated for H. pylori. Okay, well, this is a big bucket of information, right? And we're going to try to figure out what's really happening with the patient. So the first thing that happens is, first and foremost, the EKG is sent to the physician, and the physician says, that EKG looks real. I think this is a STEMI, okay? And he gets admitted to the hospital. Our cardiologist comes and looks at him and says, yeah, this isn't a STEMI. This is early repolarization, okay? Now, following that, not before, but after, his troponin level is 0.00. His HS troponin is less than 2. Remember, for men, it's got to be 20 or greater. And he doesn't even meet point of care troponin criteria, which is 0.04. Now, when we look at his EKG, we're going to see that he has anterior ST segment elevations on his EKG. And his EKG looks like his old EKG. He's had a bedside echo. Everything looks normal. He's had chest pain now. Here they say, oh, for 6 hours. But remember what the patient said? For a year. So it didn't sound like a STEMI, did it? Could have been, but it didn't sound like it. Okay, so let's look at his EKG. So this is, I don't always have the opportunity to look at an EMS EKG. This is the EMS EKG. And actually, you're just seeing right here some ST segment elevation. And right here, some ST segment elevation. So in V3 and V4. Okay, so it was a good decision for EMS to transmit the EKG. The emergency room physician said, this is a STEMI. This looks like a STEMI. So really important to appreciate once the patient got into the emergency department. Whoops, here is this EKG. So this is the second EKG. And you can see here, ST segment elevation, ST segment elevation, ST segment elevation, all the way across the precordium and all of the chest leads. Pretty easy to call that a STEMI. I probably would look at that and say, I think that looks like a STEMI. The patient's having chest pain, haven't got his troponin back yet. This looks kind of concerning. But remember that V5 and V6 are lateral leads, so I would have expected ST depression in 2, 3, and AVF, and also one other aspect. So I'm going to use my cursor to show you this is a concave ST segment elevation. Do you see how it kind of slopes inwards? That is almost always non-acute coronary syndrome, concave. But this was absolutely right to have a cardiologist look at it because it looks like a STEMI. Okay, next patient. So let's look at his EKG first, and then we'll come back. You can see it's very, very tachycardic. Do you have concern about this patient in terms, you can't even tell where his R wave is, right? Because everything is all mixed up together. But I can guarantee you that he has ventricular hypertrophy. Would you agree? You can't see the beginning or the end of the R wave and the S wave. We have a physician here. He's the chief of cardiology. His name is Dr. Alan Dollar. Dr. Dollar will say, if you cannot differentiate the R wave from the S wave of the lead below, you have hypertrophy. This patient's got hypertrophy. Okay. What we want to remember about hypertrophy is going to present with some ST segment abnormalities. First of all, with hypertrophy, you'll have some ST depression in the leads on the hypertrophied side. And because we're looking at LV hypertrophy, we're going to expect to see some ST segment elevation, V1, V2, and V3. Now, this was a pretty significant patient, okay? So we're going to look at him, 38-year-old feeling unwell, and a woman, and she's having trouble catching her breath. Her shortness of breath gets worse when she's moving, and she feels as if her legs are going to go out from under her. Previous medical history of hypertension, and she has preserved a heart failure with a reserved ejection fraction. So when we talk about that, it's called REF, reserved ejection fraction. Her ejection fraction is 40–45%. So we already know she has some heart failure. She has lupus, which is probably the cause of her heart failure. She also had a mitral valve replacement with a metallic valve, and she's compliant with warfarin. She's a sick woman. She's really sick. So she's brought by EMS to the door. No EKG was performed. Actually, I'm sorry, she was a walk-in, and she comes into the ED and she has tachycardia, hypertension, a rapid respiratory rate, no temperature, and her HS troponin is 111. Okay, so right away, you looked at her EKG. She had some ST segment changes, probably from hypertrophy. She has heart failure. She has a chronic cardiac condition. Chronic cardiac conditions will make troponin elevated. That's why you have to look at it in the context of the situation. We know this patient has lupus. We know she has heart failure. We know that she has hypertension. We now also know from looking at her EKG that she has hypertrophy. We're going to expect a high troponin. What that means is after the first troponin is drawn at hour 0, the second troponin must be drawn 1 hour later, even if first troponin hasn't resulted, okay? That's really important because for a patient with a chronic cardiac condition, you will always expect that troponin is elevated on the first troponin. You draw the second one to see if it continues to elevate. If they continue to elevate, and if that change is greater than 5, then you know this is acute. That's why you have to look at 2 troponins, first and second. draw the first at whatever time they drew it. Let's just say that they drew it at 9:28. The second one should be drawn at 10:28. You do not wait like they did here, where your first troponin at 9:45, your second troponin was drawn 3 hours later. That's not how we do it. Hour 0, hour 1 in the emergency department. Okay, so everybody was pretty worried. This physician was pretty worried. He said, let's activate STEMI because she's got an elevated troponin. Look at her BNP is also elevated. And so they activated that STEMI alert. But then they kind of took a look at POCUS. They kind of evaluated the patient. They said, we're not going to go to the cath lab emergently. We're going to look at this patient. The patient has heart failure. It's a chronic condition. And look at her BNP. So remember, normal BNP is less than 200. Her BNP is 1589. Again, this is kind of a confusing patient, although I think very clearly, when you look at her EKG, you can see that she has severe hypertrophy. So again, I would not recommend that any physician or any provider activates the cath lab. I think you have to have a cardiologist take a look at the patient, and that did indeed happen. So that was great. And also, it's not really worrisome if we activate the cath lab during daylight hours. Okay, so let's take a look at this patient. All right, so looking at this patient, just the basic criteria we've talked about thus far, starting at V1, trying to get my cursor there. So starting at V1, you can see that you have a tiny little R wave there, but then you have a great big R wave in V2, and it's much bigger than the downwards wave. So this is zone of transition. Okay, so you have an early zone of transition, and you're taking a look at this, like you're up right here, and then you're downward here, and then you're downward again and again and again. So what this actually looks like is an abnormal depolarization. Probably not a right bundle branch block. It could be something else. So this is kind of a diagnostically uncertain EKG. I'll look at the first EKG, which was done at 11:33, and the next EKG, which is done at 12:01. And you can see that you have a little bit of resolution of this whole R wave thing that may have been related to where the leads were placed, etc. Okay, so we look at this patient, 72-year-old male with a history of colon cancer and hypertension, presents as a STEMI alert activated by our cardiologist. Our cardiologist activated that. Says that the patient has dizziness while moving furniture, and he sat down. After he sat down, he passed out, hit his mouth, but he has no other head trauma, and he's asymptomatic, and the syncopal event was witnessed by family members who provided information, I believe, to EMS. He never had any chest pain or shortness of breath, and this has never happened before. So he's brought to our emergency room. He has an EMS EKG. That's the first one. STEMI alert activated by EMS, brought into our resuscitation room. Point of care troponin is 0.00. And actually, Dr. McDaniel didn't initiate the STEMI alert. Dr. McDaniel canceled the STEMI alert. Okay, so why is this all so important to us? This is also important to us to recognize that lots of things look like STEMI and they're not, right? They look like STEMI, but they're not STEMI, okay? So this patient actually had some significant other conduction deficits and disorders. Okay, let's take a look at this patient. All right, so again, just remembering when we look at our R wave progression, time and voltage, you can see zone of transition occurred here in V1. So we already know that's abnormal. The QRS is wide, right? So this is a right bundle branch block. Right bundle branch block is going to give me some electrical changes that might be interpreted by someone who doesn't know how to look at an EKG as possibly being a STEMI, okay? So we'll go back and we look at this patient, 59-year-old, found down by wife on floor next to his bed. Last seen normal at around 12 noon today. It's 2100. So states he's getting out of bed to get some water. He slipped. He fell to the floor. Couldn't get off the floor. He says he don't have any pain, no physical injury. But EMS said we couldn't evaluate a blood pressure. There was no flow. We couldn't get an oxygen saturation. He had very poor blood flow. They put him on oxygen. He has COPD, chronic hypoxia, respiratory failure, He has type 2 diabetes, coronary disease, hypertension, lots of things, right? So he comes to the hospital in through the emergency department, and the resident says, he's got a right bundle branch block. His troponin, first troponin is 300, and his second troponin is 253. So his troponin went down, which means not an acute process. Cool? It's a really great way for us to look at our patients. So really important. Okay. I really do think I had somebody who was a cardiac patient. So let me just look really quick. Nope, nope, nope. All right. So let's go to this patient. This will be our last one. This is a bonus patient. 63-year-old woman with medical history significant for PAD, hypertension, hyperlipidemia, 20-pack per year smoking history, presented to the emergency department after being woken from sleep with severe indigestion, nausea, and emesis. The key cornerstone signs in a woman for acute coronary syndrome: indigestion, nausea, emesis. They don't present like men. They don't say, oh, something's on my chest. They usually have nausea and emesis. She arrives to the ED. She's mildly hypotensive, 102/61 with a heart rate of 70, saturating 94%. She had had a dobutamine stress echocardiogram 1 month prior, which was unremarkable. Well, for me, the fact that she had a dobutamine stress test tells me something, right? She may not know everything. She might not be sharing everything, but she had a dobutamine stress test. So now look at her EKG. Okay. So first and foremost, she has poor airway progression. She has early zone of transition. She has a right bundle branch block, but she also has significant ST segment elevation, V3, V4, V5, and V6. Okay. Now, what's also really important is that she has abnormality in lead 2 AVL1, which doesn't necessarily guide us to anything. But what is really important here is in the one extreme right-sided lead, AVR, she has ST segment elevation. That is completely abnormal. So then we take a look at her chest X-ray. Chase, tell me what you see on that chest X-ray. Okay, her heart is on the right side, not the left side. So her first EKG was the left-sided EKG. That was really important. Patient had dextrocardia. She still had a STEMI, but it was a dextrocardia STEMI. So really, really important when we looked at that patient. So very significant. And of course, this patient did indeed go to the cath lab, did actually receive a PCI, and had some resolution of this. She has that right bundle branch block, and everything looks so abnormal here. I'm not telling you I would look at that EKG and say, oh, I think that patient has dextrocardia. Typically, the only reason you suspect dextrocardia is because the patient tells you, or because you see it on a chest X-ray. So that was our bonus. Okay. So in conclusion, EKG is a main stem of diagnosing STEMI, which is a true emergency. Remember, what you want to look at is the history and presentation of the patient. Does the patient have ST segment elevation in contiguous leads? Do they have reciprocal changes? And really utilizing that information to make a fantastic diagnosis. But the majority of time, patients are not presenting with STEMI. Most commonly, it's LVH, left bundle branch block, can also be pericarditis, can be early repolarization, can be a lot of reasons that we might not be equipped to diagnose. But what we want to really remember is the simple things that we can do when looking at an EKG. Is your current going towards the left, which means downwards in V1, upright in V6? Is your current going to the left, which is normal? Is too much current being employed? That means greater than 10 millimeters, either on the right and on the left, right? So in the downward direction and the upward direction. And is the R wave wide, which indicates a bundle branch block? So when we're looking at STEMI, only you can actually say whether or not you think this is a STEMI or whether or not you think we need advice. So again, looking at your EKG, look at the R wave progression, look at the height and depth, and look at the time it takes for depolarization to occur. That can really assist you in evaluating whether or not this patient actually meets STEMI criteria. All right, my friends, very good. I'm very grateful that you joined today. I'm actually happy to have you, and I hope I'm going to see you again on Tuesday Topics next week or on